Welcome to Paper Trail, where we make academic research accessible and engaging. Let's see what the evidence says.
Okay, so imagine this. For every 5 COVID-19 deaths we officially counted in the first 2 years of the pandemic, there was another one we completely missed, just gone from the record.
And not just missed randomly either. These were deaths that, according to a groundbreaking new study, were systematically undercounted, disproportionately affecting some of our most vulnerable communities. It's a stark revelation.
Nearly 156,000 hidden deaths, pushing the total for that period from around 840,000 to almost a million. That's a 19% increase. It's like finding a whole hidden chapter in a history book we thought was complete.
A chapter that was, in many ways, written by an AI, which is what makes this research so fascinating. It completely rewrites our understanding of the pandemic's true human cost.
That 19% figure, that nearly 156,000 unrecognized deaths, is just staggering. We knew there was likely an undercount, but this study quantifies it with a precision we haven't seen before.
Absolutely. For so long, our understanding of the pandemic's true scope has relied on excess mortality models, which essentially compare total deaths to historical averages. And while those models are incredibly useful for getting a broad sense of the impact, they can't tell us why those extra people died. Were they direct COVID deaths or indirect effects like delayed healthcare or economic stress?
Right, it's like knowing more people died than expected in a house, but not knowing if it was a fire or a structural collapse or something else entirely. This new AI approach, as I understand it, tries to get much more granular.
Exactly. The researchers in this Science Advances study set out to answer that specific question. How many of those excess deaths were actually COVID-19, even if not officially recorded as such? Because as the study authors emphasize, accurate mortality data isn't just an academic exercise, it's the bedrock of public health.
Bedrock is a powerful word there. Why is it so critical to get these numbers right, especially in a crisis?
Think about it. Without accurate figures, how do you know where to send resources? How do you craft public health policies, like mask mandates or vaccine distribution, and then evaluate if they're actually working? If you don't know who's dying and where, you're flying blind. Andrew Stokes, one of the co-authors from Boston University, really drove that point home, saying accurate and timely surveillance is critical for preparedness and response.
So these aren't just numbers on a spreadsheet. They represent communities, families, and ultimately our ability to learn and respond better in the future.
Precisely. And what's particularly striking is that this undercount wasn't just in the chaotic early days. The AI model estimates a huge peak of uncounted deaths in January 2021, some 35,000 in that month alone. And even during the Omicron wave in late 2021, significant undercounting was still happening. It challenges the idea that we eventually got our reporting act together.
That's fascinating. It suggests a more persistent, systemic issue rather than just a temporary breakdown during an initial shock. So how did they pull this off? How do you find missing deaths when the official cause of death isn't COVID-19? This is where the AI comes in, almost performing a digital autopsy.
It's a really clever approach. The fundamental problem, as you said, is that COVID-19 isn't listed on the death certificate. So the researchers had to teach an AI to recognize the signature of a COVID-19 death, even if the explicit label wasn't there.
Okay, so how do you teach an AI to recognize something that's technically hidden? What was their training ground?
They started with what they called a gold standard dataset. This consisted of 1.88 million in-hospital deaths from March 2020 to December 2021. Their key assumption here, which is supported by other research, was that in a hospital setting, COVID-19 testing was much more universal, especially during that period. So if someone died in a hospital and COVID-19 was involved, it was highly likely to be accurately recorded.
That makes sense. Hospitals would have the resources and protocols to properly diagnose and document. So this gold standard was essentially a perfectly labeled dataset.
Exactly. They then trained 16 different machine learning models on this data, and the one that performed best, with the highest predictive accuracy, was an extreme gradient boosting model, or XGBoost. It's a very powerful and widely used algorithm for these kinds of classification tasks.
And what exactly was the AI learning from these death certificates? Was it just looking for keywords?
It was much more sophisticated than that. The model was fed the actual text from the death certificates, focusing on two main areas. First, the contributing causes of death, so things like acute respiratory distress syndrome, pneumonia, diabetes, cardiovascular disease, and second, the decedent characteristics, age, race, sex, education level.
So it wasn't just looking for pneumonia, but pneumonia plus a specific age range plus certain comorbidities? It was identifying complex patterns.
That's right. It learned the intricate combinations of conditions and demographic profiles that were hallmarks of a confirmed COVID-19 death. Think of it like a medical detective, learning to spot a specific criminal's MO by analyzing hundreds of past cases.
Once this digital detective was trained, where did they unleash it?
They then applied this trained model to a much larger and much murkier dataset, 3.85 million death certificates for adults who died outside of a hospital. This includes deaths at home, in nursing homes, in hospice care, or even in emergency rooms where a definitive diagnosis might not have been made. In these settings, testing was far less common, especially early on, making misattribution much more likely.
Ah, so this is where the ghosts would truly reside. Deaths that were attributed to, say, heart failure or dementia, but were actually exacerbated or directly caused by an unrecognized COVID infection.
Precisely. The AI's job was to go through each of these out-of-hospital certificates and, based on the patterns it had learned, predict the probability that COVID-19 was the underlying cause, even if something else was listed. And the results were stark, particularly for deaths occurring at home.
How stark?
The model predicted that the true toll of COVID-19 deaths at home was a shocking 160% higher than what was officially reported. Think about that. For every 5 deaths officially attributed to COVID-19 at home, another 8 were missed. It really highlights a critical blind spot in our death investigation system.
That's an astonishing figure. It makes you wonder how many families grieved thinking it was just old age or an underlying condition, never knowing COVID-19 played a role.
What this AI model revealed is that the undercount wasn't just a random statistical error. It was deeply, systematically inequitable. The ghost toll, as the study calls it, disproportionately affected specific regions and marginalized communities.
That's one of the most profound takeaways from this research. It paints a grim picture of how inequality was literally etched into our pandemic mortality data. The first thing that jumps out is the geography.
Which regions were most affected by these unrecognized deaths? The highest rates were concentrated in the southern United States. The researchers calculated an adjusted reporting ratio, or ARR, to measure the degree of underreporting. An ARR of 1.50, for instance, means the estimated death toll was 50% higher than the official count.
And the top states?
Alabama led the pack with an ARR of 1.67, meaning their true death toll was estimated to be 67% higher than reported. Oklahoma was at 1.51 and South Carolina at 1.47. Overall, the southern U.S. had a 31% gap between the estimated and official death tolls.
So nearly a third more deaths than officially recognized in the South. That's a huge disparity. And this aligns with other research, doesn't it? Areas with fewer primary care physicians, less access to health insurance?
It absolutely does. It reinforces that existing healthcare infrastructure and access issues played a significant role. But the inequities become even more stark when you look at the demographics.
And that means racial and ethnic groups, I presume.
Yes, the model found that virtually all non-white groups experienced higher rates of unrecognized COVID-19 deaths compared to white individuals. The Hispanic population was the most affected, with an ARR of 1.31, meaning their true death toll was likely 31% higher than reported.
Wow, 31% higher. That's a massive oversight for one community.
And it continues with other groups. The American Indian and Alaska Native population saw an ARR of 1.24, as did the Asian population. For the Black population, the undercount was also significant, with an ARR of 1.19.
So, while the largest absolute number of unrecognized deaths was among white adults, simply because they are the largest demographic group, the rate of undercounting was significantly higher for communities of color.
Exactly. This isn't just about raw numbers. It's about the proportional impact and how certain groups were systematically erased from the record at a higher rate. And the study didn't stop there. It also looked at socioeconomic factors.
And what did that reveal?
A clear correlation. Individuals with less than a high school education were significantly more likely to be uncounted, with an ARR of 1.29. This contrasts with those with some college, where the ARR was 1.15. They also found that counties with the lowest household incomes had the highest rates of unrecognized deaths.
So, the familiar pattern emerges. Those already facing the most disadvantages, whether due to race, ethnicity, income, or education, were also the ones whose deaths were most likely to go uncounted. It's a tragic echo of existing disparities.
It is. The data shows unequivocally that the Americans who were already the most vulnerable were also the most likely to be erased from the pandemic's official death toll. It's a profound statement about whose lives and whose deaths are considered visible in our society.
This leads us directly to the author's powerful, almost provocative interpretation of their findings. They don't pull any punches, saying these patterns are evidence of structural racism, classism, and ableism within the U.S. death investigation system.
And it's crucial to distinguish here between what the data shows and what the authors interpret from it. The data unequivocally shows a statistically significant correlation between a person's race, ethnicity, income, education, and geographic location, and the likelihood their COVID-19 death went unrecorded.
So the correlations are empirical. The interpretation then is that these correlations are not random, but symptoms of a flawed and biased system.
Exactly. And they lay out a compelling case for why these systemic failures exist. One major factor they point to is the fragmented nature of the U.S. death investigation system.
Oh, you mean the difference between coroners and medical examiners?
Precisely. We don't have a unified national system. It's a patchwork of over 2,000 different jurisdictions. Some are served by trained medical examiners, physicians specializing in forensic pathology, while others rely on elected coroners, who might have no medical training at all. This fragmentation inevitably leads to inconsistent quality and standards in determining cause of death.
That makes perfect sense. If you have someone without medical training making critical determinations, especially in a complex pandemic, you're bound to have discrepancies.
And then there's the unequal access to testing and healthcare, which was a huge issue, especially early in the pandemic. Listing COVID-19 on a death certificate often depended on a positive test result. If marginalized communities faced barriers to testing facilities, or if they didn't have a primary care physician to begin with, then their deaths were much more likely to be attributed to a pre-existing condition.
Like dying at home, where we saw that 160% undercount. If you don't get tested and you die at home, it's easy for that cause of death to be missed.
Right. And then we have the more nuanced but equally critical issue of implicit and explicit bias. The process of determining a cause of death isn't always purely objective. Studies have shown cognitive bias can creep in, where a certifier might be more likely to attribute the death of a person from a marginalized group with multiple comorbidities to those underlying conditions, rather than to the acute COVID-19 infection that pushed them over the edge.
So it's not necessarily malicious intent, but a subtle bias that influences how a certifier interprets the available information, particularly when dealing with someone who already faces health disadvantages.
That's where the term ableism comes in. The paper specifically mentions it. It's the idea that a person's pre-existing conditions or disabilities are used as the primary explanation for their death, obscuring the role of an external factor like a viral infection. Legal scholars have even highlighted how conditions like sickle cell trait have been cited in deaths caused by state violence, effectively shifting blame from an acute event to a pre-existing condition.
That's a powerful and disturbing comparison.
And finally, these factors coalesce under the umbrella of structural racism. This isn't about individual acts of prejudice, but the laws, policies, practices, and norms that perpetuate racial inequity. Residential segregation, underfunded healthcare systems in minority communities, higher rates of pre-existing conditions due to chronic stress and environmental factors, these all made people of color both more likely to die from COVID-19 and less likely to have that death officially counted.
So the study isn't just saying there were disparities, it's arguing that the disparities are a direct consequence of how our society is structured and how its systems operate.
Exactly. It provides quantitative evidence for what many have long argued. The systems meant to serve and protect the public often fail marginalized communities, and this failure extends even to how their deaths are recorded and remembered. It's a stark reminder that data isn't neutral. It reflects societal structures.
This study really showcases AI's power to uncover hidden truths in historical data, but it also opens up a whole new set of ethical questions. It feels like a double-edged sword.
It absolutely is. On one hand, this methodology is incredibly promising for public health surveillance and understanding past crises. Andrew Stokes, the lead author, even suggested it could be applied to uncover undercounts in other areas, like suicide mortality, Alzheimer's, or drug overdoses.
So AI could essentially become a tool for historical forensics, digging into old records to correct our understanding of past health trends. That's a powerful promise.
Imagine the potential: faster, more accurate assessments during future health crises, enabling quicker and more equitable responses, or even integrating AI into electronic death registration systems to provide real-time feedback to physicians, flagging improbable causal chains, or prompting for more specific information, thereby improving the quality of mortality data at the source.
That could be transformative, improving data quality as it's being created, not just retrospectively. But you mentioned a double-edged sword. What are the risks here?
The biggest risk, and one that the researchers are keenly aware of, is algorithmic bias. An AI model is only as good as the data it's trained on. If historical data is biased, for example, if certain populations have been systematically underdiagnosed or undertested in the past, then an AI trained on that data will learn and replicate those biases.
So the gold standard training data itself, while the best available, might still have subtle biases that the AI would then encode into its predictions. The classic garbage in, garbage out problem.
Precisely. It's a foundational concern. Then there's the issue of public trust. If official statistics are constantly being revised by what can feel like opaque black box algorithms, it could erode public trust in government and scientific institutions.
We've already seen so much skepticism around official numbers during the pandemic, and AI coming in and saying, actually, it was even worse and here's how, could be met with either acceptance or deep distrust.
Exactly. That's why transparency and explainability, what we call XAI, are absolutely critical. The public and policymakers need to understand how the AI reached its conclusions, not just accept them blindly. Without that, there's a real risk of these AI-generated statistics becoming another source of misinformation.
And of course, we're talking about sensitive personal health data here. Even if it's deceased individuals, privacy and data governance must be huge concerns.
Absolutely. These models rely on analyzing vast amounts of personal and sensitive health data from death certificates. Strong governance frameworks are needed to protect the privacy of the deceased and their families, and to ensure the data is used ethically. Clear guidelines around consent, data ownership, and security are non-negotiable.
So AI can tell us what happened, but it can't tell us what to do about it. That's still a human responsibility.
Exactly. AI should be seen as a tool to augment, not replace, human expertise. The final interpretation of AI-generated data and the resulting policy decisions must remain in the hands of public health professionals, ethicists, and community stakeholders. A human-in-the-loop approach is essential to ensure that the technology is used responsibly and that its outputs are critically evaluated in their proper social and historical context. This study is a powerful demonstration of AI's potential, but it's also a crucial reminder that as we develop these powerful tools, we must simultaneously develop the ethical frameworks and safeguards to ensure they are used to promote equity, not entrench existing disparities.
So, to synthesize this truly eye-opening study, what are the key insights we should carry forward from this discussion?
I'd say, first, acknowledge the sheer scale. The official U.S. COVID-19 death toll was massively undercounted. We're talking about nearly 156,000 unrecognized deaths, pushing the total for the first 2 years to almost 1 million. That's about 1 in 5 deaths missed.
And second, this undercount wasn't random. It was deeply inequitable, disproportionately affecting racial and ethnic minorities, particularly Hispanic individuals, those with lower income and education, and people living in the southern U.S.
Third, and crucially, the study's authors interpret this pattern as reflecting systemic biases within the U.S. death investigation system. They point to structural racism, classism, and ableism, manifested in things like unequal access to care and testing, a fragmented coroner/medical examiner system, and potential biases in how causes of death are certified.
And fourth, the methodology itself is a game changer. Using an XGBoost machine learning model to reanalyze death certificates offers a powerful new approach for retrospective public health analysis, providing a much more granular understanding of mortality crises than traditional methods.
Finally, it's a stark reminder that while AI offers immense promise as a corrective tool, its deployment comes with critical ethical imperatives. We need to prioritize data equity, algorithmic transparency, robust data governance, and meaningful human oversight to avoid perpetuating the very biases we're trying to uncover.
It leaves us with a lot to ponder. How do we ensure that the lessons learned from this AI-driven reanalysis translate into meaningful, equitable change in our public health systems? And how can we build public trust in these powerful new tools without sacrificing critical human oversight?
Keep reading the fine print.